Broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to today's webinar session, Improving Discharge Care for Children with Special Healthcare Needs through a Nurse-Led Learning Collaborative. Next slide. My name is Jenny Baird, and I am the moderator. I am the director of the Institute for Nursing and Interprofessional Research at Children's Hospital Los Angeles, and the principal investigator of the Candle Collaborative that we're going to tell you a bit about today. We are recording this webinar, and it will be available on the Lucille Packard Foundation for Children's Health website in the coming weeks. Next slide. Joining me today are a great group of speakers. We have Kevin Blaine, who's a Senior Research Associate at the Institute for Nursing and Interprofessional Research at Children's Hospital Los Angeles and the Director of the Candle Collaborative. We have Angie Marin, who's a Nurse Manager at UC Davis Children's Hospital. We have Melissa Gustafson, who's a Pediatric Nurse Practitioner at Lucille Packard Children's Hospital at Stanford. And we have Sarah Wilkerson, who's a Pediatric Nurse Practitioner at Monroe Carroll Jr. Children's Hospital at Vanderbilt University. Thanks to each of you for joining us today to share your work. Next slide. We want this to be an engaging conversation and encourage all attendees to submit questions in the GoToWebinar question box. We will try to get to as many of them as we can today. Kevin, I'm going to now turn it over to you.
Hi, everybody. Thanks so much for being with us today. We're really excited to share with you about some of the work that we've done here at the Candle Collaborative. First, CANDLE, what does it stand for? CANDLE is the California-based nurse-led discharge learning collaborative. And our mission really is to advance systems level changes in discharge care delivery for hospitalized kiddos throughout and outside of California via the joint piloting and refining of local quality improvement interventions and initiatives that kind of support new evidence-based standards of pediatric discharge care that were developed in partnership with the Packard Foundation over the last couple of years. This really is kind of the next step of that work. And our vision together is that our institutions become beacons of hope for families navigating the discharge process, really hoping to do that as we learn from each other and jointly pursuing practical, sustainable, and meaningful change locally. This work really began in 2013 with the creation of 10 standards of discharge care, and over the subsequent years, they've kind of been refined and tested at kind of single hospital sites. And this phase of the work, the kind of creation of the Candle Collaborative, really is the operationalization of the standards themselves, kind of across multiple sites in a way to standardize discharge care. And so I want to share with you a little bit about how we did that, some of the activities the group did, and a little bit of where we're going. Next slide. The guiding principles of our work, first and foremost, was participatory action research with our collaborative members and their local teams really serving as those participants in this work. Subsequent kind of frameworks that we leveraged were deeper learning, interdisciplinary partnership, and institutional collaboration, and kind of mix all those together in this colorful diagram. And the hope is that we have outcomes of meaningful change and long-term cross-institutional relationships that have sustainable action and increased capacity locally. Next slide. So PAR, what are we talking about? Participatory action research is known in public health and kind of communities, but it's relatively new as a concept to be implemented at a hospital level among our clinical colleagues. At its core, it's a social research approach that seeks to create knowledge that's informed by and most importantly, responsive to the needs of participants themselves. It's about translating ideas into action, and in a lot of ways, it disrupts the traditional research paradigm. Next slide. So this is what it is in action. On our left, under activities, you see these are the typical things you see in research. You define the problem, you implement and test solutions, you analyze, you disseminate findings. This is how it translates in PAR. So when we define the problem, we're leveraging local knowledge and current pressure points. and where participants are the ones that design the tools and weigh in on intervention rollout as it's happening. They assist with data collection, and when we analyze the data, they're full partners as part of it, looking at those things that are local, actionable, and immediately relevant to share. So PAR really was the cornerstone in the work of the collaborative. Another cornerstone, next slide, was focusing in on 3 of the discharge standards. So I mentioned before there were 10. That was going to be way too much to focus on, so we decided to kind of prioritize, and we went through a systematized process to figure that out, and this is where we landed. So the 3 standards that we focused on were making a comprehensive and responsive discharge plan, which means making a plan to achieve every discharge goal, meet every discharge need, and address every factor that could impact post-discharge care. We focused on exchanging and confirming discharge plans with the family post-discharge providers, which means sharing documents to the family and providers ahead of time, so there are opportunities to respond to and ask questions before discharge occurs. And lastly, we focused on ensuring family readiness for discharge, and we've defined readiness as the family's perception and the provider's assessment that 1, the child is healthy enough to leave the hospital, and 2, the family is confident and competent enough to care for their child after discharge. So this is kind of what we've had in our minds throughout all of phase 1 of the collaborative, and we're still very much keeping these in mind for phase 2. Next slide. So this is how the collaborative was organized. We had our participating hospitals. These are the blue bubbles. And at the core, kind of supporting them was a core team and an advisory panel of national experts in discharge care and family advocacy, including Family Voices of California. And the core team really supported these joint discharge improvement initiatives through facilitating communication, providing analytic support, managerial and operational support, and resources. And those little arrows that you see really are about phase 2, which is we're kind of right now in a place, which I'm excited about, and we're going to share with you, I'm sure, at a later point, of we're sharing some of the work that happened at our own institutions and finding ways to cross-implement it. Next slide. And so how did we do all that? Well, there were 4 activities that we really leaned into. The first was in-person meetings, where we could build community and facilitate meaningful relationships between each other that would allow for well done group decision making that we were all on board with. It allowed us to review best practices and materials and resources. That was supported by online webinars where we came together as a core team to kind of share what we were seeing at a higher level, and we could group problem solve. We also brought in some keynote speakers with subject matter expertise to help build capacity at each around quality improvement at each of the hospital sites. And then we also did one-on-one coaching calls with each local team where they were able to report progress to the core team, and we could jointly celebrate successes and problem solve really specific issues. And lastly, we had some site visits in person, all pre-COVID, of course. And this was where we could have focused listening sessions with those local team members and observe their changes in real time and have one-on-one brainstorming sessions. So I wanted to share all of this about the collaborative in order to set up our next 3 speakers who are really the stars of the show. We have members of the collaborative to share about their own work, the local quality improvement work they did as part of phase 1 of this work, and then to share a little bit about what it was like to participate in the collaborative. So without further ado, I want to present Angie Marin of UC Davis Children's Hospital to talk about her work.
Thank you, Kevin. Thank you for having me today. The work we did here at Am I unmuted now? I'm sorry. Can you hear me?
Yeah, you're all set.
Okay, sorry about that. I hit the wrong button as usual. So again, I'm Angie Marin from UC Davis, and thank you, Kevin, for that welcome. I'm here to talk about our daily discharge huddles. And next slide, please. So a brief description of this is that we wanted to have an interdisciplinary daily discharge huddle to identify the barriers and issues for our patients expecting to be discharged in the next 48 hours. family and the primary nurse would be notified of this expected discharge as well. And part of the participants of this huddle was our case manager, our PT, OT, the charge nurse, the attending physician, and social services. Next slide, please. So some of the key components that we had already been doing is there had been a pre-discharge huddle meeting with the charge nurse and the case manager to kind of review the children that would be discharged that day and if there was any barriers, and this was day of discharge. The charge nurse also realized that OTPT wasn't always coming to the huddle because the huddle time interfered with their ability to be present since they were delivering patient care. So they started communicating with the charge nurse before the huddle to let her know which patients would be ready for discharge that day or the following day. The case manager was the consistent person daily there Monday through Friday, so it was decided that they would lead the huddle, and that would be so that we wouldn't have different people running the rounds. The discharge huddle afterwards, the charge nurse's responsibility was to ensure that the family was connected with and discuss the discharge and determine family readiness. The charge nurses would also share this information, the discharge huddle, with the nurses and the oncoming nursing staff so that they could anticipate the child going home in the next 24 hours. Next slide, please. So one of the tools that we realized we needed to make was a way to track the progress of this huddle, and we wanted it to be quick and efficient since it was changing every day. We didn't want to take a lot of notes. We just wanted to make notation that services were still involved and we could actually check their notes. So if a child was to go home, it was marked in the box discharge in 24 hours. If they had no needs, we simply checked no needs. If they still had needs pending from different departments, there was a check box there. This was kept at the charge nurse station and it was part of the daily report. And it helped nurses identify where we were at with patients' readiness to go home. Hospitalists were updated about the changes that would be occurring in this report by the pediatricians, and we emailed the discharge rounding tool to all of the relief charges so that they were aware of how to use it, and we actually did some orientation with them. Next slide, please. So the discharge huddle is an established meeting on our unit. It occurs at the same time every day. There are 36 children present on the unit, and we discuss all of them in a 30-minute period of time. The discharge huddle consists of the charge nurse, the case manager, the dietitian, social worker, the attending resident, child life, and any other interested parties that want to participate. Quick run through would be we ask that the physician present the patient very quickly, room number, name, diagnosis, and any issues. The charge nurse would then ask a simple question was, are you anticipating this child to go home in the next 24 hours? If the physician said yes, the rounds were quickly then stopped, and the charge nurse or the case manager would poll each of the members of the team to find out if there were any barriers or issues. So this would be where the social worker would say, we still don't have a ride for this family, or the case manager may say, we do not have DME available. But then everybody on the team kind of knew what the barriers were and the direction we needed to focus on. Next slide, please. So when we were getting ready to implement this, we did have a team of a small collaborative team here in our hospital made up of our case manager, social worker, an assistant nurse manager, and two different attending physicians to really talk about how this would look and how we would make this change to our process. We'd always had a discharge huddle, but it was never really formally managed, and sometimes it would become a discharge discussion about one or two families, and we wouldn't get through the entire unit, and a lot of things were left unclear. So we recognized that we needed to adapt and organize our information. We thought as a team it would be really nice to talk about the children who were going home in the next 24 hours, followed by the next 48 hours. But we quickly realized that this was not a workflow that the physicians were comfortable with or how they organized their work. So at the beginning, like I said, it of the huddle, we reaffirmed the goals and the purpose of this meeting, which was really to ensure that we were ready and that we could support family readiness. We started to invite the residents to come to huddle. For years, it had only been the attending, and we noticed that there was a gap in information being shared between when the attending told the resident and when the resident actually acted on some of that information. Something as simple as getting paperwork for DME oftentimes was left till the next day, and this was could delay getting it ordered or having it available for families. So we would review also at the end of the discharge huddle, any children that we had anticipated the day before of going home, we would talk about why they didn't go home and what could we have done differently as a group in identifying some of those barriers or anticipate what was needed. Next slide, please. So some of our biggest wins from this was we increased the proactivity of the members of this committee. That coming to discharge rounds was no longer one of those things where you spend a half hour of time and get nothing done. It was actually a really working meeting because you left there with a direct plan of which patients you needed to focus on for the next 24 hours, which families we needed to give more additional attention to, which nurses needed to finish up teaching or identify some of the other barriers that they were working on. It gave us an opportunity to get prescriptions ordered ahead of time, especially medications that needed to be compounded. It ensured that DME was ordered and signed for, as well as proper paperwork. Any consults that were hanging out became the focus. We also started to be able to kind of compile what was available in our community for some of our patients and recall that. We had much more accurate collection, the case manager said, of getting their forms filled out, having things done, actually started bringing them to the huddle, and the residents or the attending would sign them right there. We just improved the time management to the point where the physicians had additional time to talk about patients that were housed on our other pediatric units. So we're now able to, at the end of this, review 48 children instead of the additional 36. And then I think one of the other biggest wins was this really reduced the coverage for the weekend case managers and social workers, because there was really clear plans left in the chart as to where we were with that child's documentation of their discharge. Next slide, please. So in hindsight, while we realized that the case manager was the most consistent person on our unit and available on a day-to-day, daily, they really don't have the authority to oversee a bedside nurse's assignment. The accountability, authority, and responsibility for that nursing care and discharge teaching is really at the hands of the bedside nurse, and the person that can ensure that they have the time to do that is really the charge nurse. So we went back to having the charge nurse actually run the huddle and direct some of the questioning to the physicians, and that so we could get more clear information. We also put a focus and an emphasis that should be placed on this early notification of the nurse and the family, because that really does impact the readiness. We did notice that with some of our readiness documentation that families, after we implemented this, did feel ready, did indicate that they felt readier for discharge. We've now added a lot of this to our IPASS huddle, our IPASS rounding, and so that going back in after discharge rounds and talking to families is just reaffirming what they already know. Once the attendings started bringing the residents to the huddle, we saw a real increase in follow through with orders and family communication. And I think it was also really beneficial for the residents to understand the discharge process and all the pieces that needed to go in it. It wasn't just, oh, you're ready to go home. And during this process, we also noted the participants in the huddle were much more proactive. They came ready to participate in this. They came ready with what they needed, and they were more willing to ask in this forum for what was still necessary for this patient to be able to go home. Big thing was forms being signed, specific orders being ordered, and compounded meds. Next slide, please. So our advice to others is just think small. Changing practice of others, while it may seem simple, is really, really difficult. We learned our lesson here that while we thought it was really easy to talk about patients in sense of order of when they're ready to go home, that was a real difficult change for the physicians. And we realized early on that we couldn't change their culture, and it was just easier for us to adapt by just asking the simple question at the end of their presentation: do you anticipate this patient going home tomorrow? That really facilitated a lot of dialogue, to where now even the residents will say, before we even say it, I don't anticipate this child going home tomorrow. It allowed us to individualize the tools and adapt for the information that we needed. We're working right now with our Epic to see if there's a way we can get a report in the computer so people can actually see where we are with the discharge plan, and we don't have to have extra sheets of paper. And we needed to also recognize that the most consistent contact with this patient and family is the bedside nurse, and involving them early on and getting their input on the discharge is really important. Also reinforcing that bedside nurse's role to facilitate that family readiness for discharge. And now I'm going to pass this off to Melissa.
Thanks, Angie. Again, my name is Melissa Gustafson. I'm a nurse practitioner here on Lucille Packard Children's Hospital, and work in the inpatient role with general pediatrics, but more of my focus is on children with medical complexity and our complex care inpatient team here. And so we know from the literature that the most precarious times for our children with medical complexity involves transitions of care, mainly from admission, between units, and then to home. So our group, to address these risks, decided to focus our efforts on medication safety during times of transition. So the aims were to describe implementation of a pharmacist-led medication surveillance program, which would then improve communication and education about our medications, and then hopefully increase our family and provider perceptions of readiness for discharge. And next slide, please. Brief description of our intervention was more to standardize the role of our pharmacist on our team, a pharmacist who was skilled in the transitions of care. Her role was more to review the medications with families and care team upon admission, monitor therapeutic regimens during hospitalization, and dedicate discharge teaching with families that include these creation of a med action plan, MAP, as you see, and review with families during teaching and at the time of discharge. She also helped with the assistance of discharge medication process and review and assistant with prior authorizations. Next slide. More components of this is to further focus on these transitions home, we implemented a workflow that I will describe in a little bit. But really it came down to the NP and dedicated discharge pharmacists working together and collaborating with families and nursing staff about 25 hours or 24 hours prior to discharge to help identify these families and complete tailored med action plans for these patients and families, and reviewing it at the bedside with the families and the nursing staff. And all of these med action plans were tailored by our clinical pharmacists who had training in transitions of care and making these sheets as well. Next slide. As you can see, these are some of the tools and resources that we use. This is an example of one of our med action sheets that we had used with the families. This was a more detailed list. We tried to incorporate pictures, as you can see, times, comments, and the name of the medications and the generic use as well. Next slide, please. And here is one in Spanish that we used. We made sure that all med action sheets were done in the language of preference based on our patients and family needs, and did have to utilize our interpreter services to help with this in addition. Next slide, please. So this is kind of on a daily basis what one of our children looks like inpatient that we see. Kind of gives a whole background of the complex medical systems, usually more than 3 medical systems that are involved. and how this patient, will walk you through how this patient, the transitions of care pharmacist was implemented with this. Next slide, please. So it begins with having a pre-discharge huddle with the pharmacist and the NP to specifically review the medications and meeting with the caretakers to understand, is this the correct medications that they're taking? Usually this is done on any patient coming in, but we sat at the bedside and really focused with the family. We made sure that these medications were specifically fixed in our EMR, our EPIC system that we have here, and that it was ordered correctly so everyone could see this. As the patient kind of progressed through the hospitalization, the transitions of care pharmacist would, and the nurse practitioner would discuss daily what we thought their needs may be in regards to medications, and really trying to understand about 24 hours prior to discharge when these patients would be leaving and what medications we would, they would be going home on. Once that was identified and talked, the transitions of care pharmacists created this medication action sheet for the families, reviewed it with the nurse practitioner, and we also reviewed it with the RN to make sure that it was correct, and that these were all the medications that were in the system in EPIC, and that the patients and families would be picking up from our pharmacy, specifically our outpatient pharmacy here at Lucille Packard prior to discharge. Then our discharge pharmacist and our NP would review these med action sheets with the family and the caretaker or patient 24 hours and sometimes even about 4 hours before the patients were about to leave to review if there was any concerns, comments, any changes that needed to be made. And lastly, right to the patients leaving, we connected with the family and the RNs to make sure that were there any last pending medications, any concerns about the medications that they had, any concerns about the routes, the dosing, etc. Next slide, please. We were pretty successful in implementing this, and we feel like early communication for discharge plans and this process really helps set up success for our families. We think that corrections to the medication list upon admission to avoid confusion at discharge is imperative. We know we all should be doing it, but it's not always done. And we really believe that a designated time for the discharge pharmacist and the NP to work on complex care initiatives is really needed to make this successful and to hopefully prevent delays and misintervention opportunities. Next slide, please. Based on our work, we do believe the discharge pharmacist is an incredibly valuable member of our healthcare team, especially with kids that have medical complexities. It really has the potential to improve communication and documentation. It may lead to improved medication safety. It may reduce overall healthcare use, and it provides a new platform for our pharmacists at our institution and hopefully many other institutions. It really has gotten a lot of feedback from our families on what the education and what they need prior to discharge and what they really need to know when they go home for it to be successful with it. As a result, it also has led us to focus more of our efforts on what families need, both Spanish and English speaking families, with these med action sheet plans. So we can further tailor them to meet their needs. Next slide, please. Kind of in hindsight, looking back, what would have been nice is we were lucky to have a dedicated discharge pharmacist who volunteered pretty much their time and their passion into this effort. But as a result of this, we were able to get a transitions of care pharmacy resident to work with us for the rest of the year to help assist our primary lead pharmacist on this, which has been really great and helpful now as we continue on with this project. And in addition to really continually working with our organization to try to explain the benefits of a discharge pharmacist, especially with children with medical complexity, to hopefully help us to avoid delays in care and also help to reduce errors. Next slide, please. With this, it does take some time. Obviously, you do need to have the ability to work with a pharmacist and who has the time to also help provide this intervention and really work with the family and the care team during the whole hospitalization. In addition, we may need to consider work with multiple pharmacists, not just large transitions of care, and other residents who can help with this initiative. So really looking at how you can work with all of your pharmacists in the hospital and see who can help us continue this. Next slide, please. And I will pass it now on to Sarah Whippleson from Monroe Children's.
Thanks, Melissa. My name's Sarah, and I work primarily in our outpatient complex care clinic at Vandy. Next slide. So as part of the work within the larger collaborative, we discovered that Lucille Packard had a very similar program to ours at Vandy. And due to these similarities, we found common interests for collaboration. So first I'm going to go through a little bit about how our two programs are set up. For Monroe Carroll, we're an inpatient consulting service and an outpatient continuity clinic, just a little bit different. We have the outpatient arm too. Now our program's actually about 430 patients. There's a few more statistics for you. Next slide. For Lucille Packard's, they are an inpatient medical consultative service, so they do not have an outpatient arm, and their inclusion criteria is very similar to ours. Next slide. Both of our programs have nurse practitioners and dedicated pharmacists. So the role of the nurse practitioner at Monroe Carroll is listed there for you. As I said, we're primarily outpatient. We do a lot of care in between visits, which is a very important part of our job. Next slide. And then as you can see, this is the role of the nurse practitioner for Lucille Packard. And you can see where some of the overlaps are there. Next slide. Both our institutions are extremely fortunate to have a dedicated pharmacist to our program. They are really integral in the med oversight for our patients who have polypharmacy. Most all of our patients are on at least 10 medications. Next slide. And here's the role of the Lucille Packard pharmacist. So they really are involved in medication reconciliation at every point of contact. Next slide. Prior to our specific collaboration with Lucille Packard, we've created a little slide here for you that shows where our individual interests were on the left for Lucille Packard and right for Monroe Carroll, and where our shared intervention steps were. And these were just happenstance. So we happened to be doing the same thing where the pharmacist, as I say, reviews all the medications, discharge orders, and the NPs or pharmacists are providing personalized medication teaching. Next slide. And after we began to collaborate, we really wanted to streamline a process for medication reconciliation and education at discharge so that the things we are creating as part of this collaborative can be part of a change package that can be used at multiple institutions across the country. Next slide. And as part of this, we wanted to make sure that we were really capturing the children who needed the intervention most at discharge. So for instance, if a child came in for a quick 24-hour overnight stay to watch them after a heart cath or a quick respiratory admission, they might not need medication education as much because they're not going to be started on new medications. It's more status quo for them. So we created an algorithm that we felt really nicely captured the children who were at greatest risk for medication errors, and they were scored based on that. And if a patient got a score of 15 or greater, then they got an intervention. Next slide. And so here again is our completed in the middle shared intervention steps that we, Lucille Packard and Vanderbilt, enacted with these patients who met this algorithm every time they were discharged. Next slide. And this slide just again lays out the before and after nicely, so you can see that by the end we were really doing a lot of very similar work. Next slide. So evolution of process over time, what we learned specifically for our program, because as an inpatient team, we are a consulting team, we're not an admitting team. So we learned that communication is key. Communicating frequently with the primary team in terms of meeting with them. We started a paging system where we would send them a page to request information when a patient was going to be discharged, development of the algorithm, and then the adaptation of our two processes. Next slide. So lessons learned, very similarly to what Melissa said, we really improved our discharge documentation. The families really felt like they had a dedicated time to discuss medication issues to be prepared for discharge. And they felt like the whole package was completed because their medications were available to be picked up at the pharmacy. There was no lag. When they got home, they had everything they needed. And then there were fewer medication areas of discharge, potentially leading to fewer readmissions. Next slide. And then as Melissa discussed, these are the lessons learned for them. And we have really found that a discharge pharmacist can increase the family and care team communication for sure. And even if your institution does not have a dedicated pharmacist, as Melissa said, seeing ways where you can engage pharmacy residents or other pharmacists within the hospital to help shore up discharge medications is very important. Next slide. As part of this Candle Collaborative, we have really found some meaningful relationships with other institutions that are similarly set up to ours, where we can talk with them and relate with them. And we realized that we were experiencing many of the same issues, even though we are across the country from each other. When you take care of similar patients, you run into similar issues. And it allows us to disseminate our work. We've done a presentation in Orlando. Our pharmacist just completed a conference where he did some presentation work as well. And then it allows us to build local capacity around quality improvement, design, and implementation. Next slide. And I'm going to hand it back now to Jenny to start the Q&A.
Terrific. Thank you again to Kevin, Angie, Melissa, and Sarah. I really appreciate hearing from each of you. So we're going to open up for questions from the audience, and we've received quite a few already. So I'm going to toss the first one to Kevin. We had someone ask, what can a parent ask for to get a quality discharge?
Ooh, oh man. That is a great question. All the questions. Ask all the questions. I think figuring out the question to ask is who is the one person that I can go to answer and address any question that I have about discharge. I think in our work with the Candle Collaborative, we've worked very closely with Family Voices of California, and we currently have a family advisory board for the Candle Collaborative, and it's one of the kind of constant themes in any discussion we have around discharge, which is there needs to be a single point person that knows the child, that knows the family, where there is a rapport that's established. And so I think that that's something that as a family member of a parent of a child who is hospitalized, I think having that external check of asking for accountability, like having the inpatient care team have that accountability to have that person be engaged with you when you need it, I think is super key. So I think asking for that one person, and then really utilizing that one person to answer any question, like any questions you have, because at the end of the day, I think the transition home has to be successful. And in order for that to be successful, families have to feel confident and competent enough to care for kiddos at home.
Great, thank you. Angie, we had a couple of questions about the role of the case manager. So to start, can you explain what a case manager is? One person noted that their hospital doesn't have case managers.
It can be your discharge planner. It is the person that works with the insurance companies, with the outside agencies that we may be needing to support children in home, getting them medical equipment, getting them possibly home nursing visits, setting up pharmacy in the home. So they manage that part of the discharge equipment and supplies a lot of times, and then in-home support for families. So here there are, at my facility, most of them are registered nurses that function in that role, that interface between your insurance companies and the home cares that you may need, or they could be social workers. Some facilities use social services in this role as well. And they also will network with the community for things like with Alta Regional and different community agencies that may have paperwork that needs to be signed by physicians, and that for services once you're discharged from the hospital.
Great, thank you. And then another question, someone was asking, what time is the discharge huddle and how did the group decide on that time?
Well, the time was kind of decided based on the workflow of the unit. So it's at 11 o'clock, and we wanted it to come right after rounds and right before teaching rounds, x-ray rounds, because we're an academic medical center. So we had to look at all the time constraints on physicians. And we really just said, we promise you 30 minutes of your time is going to save you phone calls and different things. So when we sat down and looked at this time of how we would come together, we were really mindful that we had to be respectful of other people's times. And I actually have three different attendings and their services on the unit that rotate through that discharge round. So it's very efficient and very scripted to stay on task with the doctors, and to where they're now lining up at the door to come in to be ready. They're like on deck because it's so valuable to them to be able to ask these questions about what their patients need or what they've been shared with. And it's been the perfect component to support our IPASS rounding, which we're now implementing here, because it comes right from the bedside with the nurse, any of those concerns that she's addressing with the family, to that resident and team, and they're coming right into this rounding report. We would love to be able to do it bedside for every family, but just the logistics of the sheer volume of patients that I have on the floor and the three teams, we can't be in three places at once. So we're making this 30 minutes a very meaningful time, and it's Monday through Friday, every day, same time, same place.
Great, thank you. Question from Melissa. Do families feel as though the 24 hours prior to discharge are overwhelming with all the new information that you're sharing with them?
Good question. So some families do experience that. I think we also try to read the families, kind of patient specific. If the family needs a little bit more teaching starting prior to that, but really the 24 hours is really understanding what they're fully going to be going home on, and hopefully no changes will be made, so we can really they have a full understanding of the medications going home. Some families do need more teaching. So again, we may start teaching right after they come onto the unit and upon admission. But it can vary a little bit, but we really tried to be mindful about the 24 hours prior. And fortunately, and unfortunately, some of these families have been admitted so frequently that they did have an understanding of the prior medications, and it was more new medications that we had to focus on. Kind of was tailored a little bit to each patient.
Great, thank you. Sarah, a question for you. This participant is noting that a discharge pharmacist would have been the key to avoiding the problems that they had at their last discharge. Do you think it would be appropriate to ask at the hospital if they have such a person, or what would you recommend related to that?
Yeah, definitely. And I think that's the hardest part for a lot of institutions, is who will be the one doing this education. And if they don't have a dedicated pharmacist or person to do it, then that sometimes falls through the crack, especially if the nurses don't feel comfortable doing it, the bedside nurses. Our institution has a lot of pharmacy techs or pharmacy residents that could potentially be freed up to come to the bedside, particularly if it's a very complicated discharge with new medications and there's concerns about medication interactions and things like that. I think it would be very appropriate to say, is there a person on the pharmacy staff that could come walk us through a few of the questions that we have and just make sure. One thing that we run into a lot in our institution, I think happens kind of nationally, is what happens after discharge when the medications are sent to the wrong pharmacy or they need to be compounded and nobody got a prior authorization. The families are left wondering who to call or how to sort it out. And so I think being proactive as a parent and asking those questions around the time of discharge to say, did this specific medication go to this pharmacy? Did someone get a prior authorization? To make sure that that is on the radar of the prescribing physician before the family leaves the hospital and realizes that the medication was sent in wrong. And we really at Vanderbilt, the way that we sort of got around that, we really about halfway through this intervention realized that all the medications for these types of patients really need to go to our outpatient pharmacy and be delivered in hand to the families before discharge, because there are so many problems we run into with prior authorizations, medications not being stocked, those kind of things.
Great, thank you. Angie, back to you. Question about how family education and readiness is ensured at your hospital.
Well, we practice primary nursing. And so that means that in the first 24 hours of your admission, a nurse is assigned to you for your entire hospital stay, and she's responsible for assisting in developing your teaching plan and communicating that with other nurses. If you're readmitted, that primary nurse and that team is the same group of nurses who care for you. And that's a little unique to our environment, and it's been our practice. So that for part of our readiness, I think that the role of the primary nurse is key in ensuring that, because they are really the ones who know you the best, who recognize what you're capable of doing, and are the ones that are respected by the physicians when primary nurses say this family isn't ready to go home. It's mutually agreed upon with the family and the nurse, and there's milestones along the way with the discharge teaching as far as if it's a new teaching or if it's something that you've already been taught and you know how to care for and you're back in with something else. So everything is very individualized, and I really think a lot of it lies in the responsibility of your bedside nurse in that relationship.
Great, thank you. Question for the group. What was the level of buy-in from hospital administration for these changes at your sites?
I can speak for UC Davis. They were thrilled. Anything we could do to ensure our families went home and they were ready to go home and they weren't returning because they weren't ready was huge for us. It also helped us because we serve Northern California, and our families have to go a long way in wanting to connect them back to their community and make sure that they were ready. So any effort we were putting towards that, I got a lot of support on.
Great. How about for Melissa or Sarah?
I'll second that. You know, hospital administrators get a lot of push from insurance companies and reimbursement standpoint to get patients out as quickly as possible, but also as efficiently as possible so that they don't bounce back. And so anything that we can do to help with the discharge happening in a more timely manner, because the education's already done and the families feel comfortable and won't come back, they feel is very helpful.
And I want to chime in a little bit too, just from what I observed throughout the implementation of phase one, is it really is about presenting the initiatives, the work of the collaborative itself through the eyes of an administrator. I think, as Sarah just pointed out, you know, there is financial incentive for, you know, these kind of improvement projects. We on the boots on the ground that are working on it, like, see that the quality piece of it, of this moral push to, you know, help families to ensure this nice transition. But when I've those conversations that aren't necessarily tailored to a hospital administrator's interests have often had a bit more of an uphill battle. And so I think tailoring the conversation has been really effective in garnering that support from leadership.
And Melissa, how about for you?
I would say it has led us, we have a big group of pharmacists here, but in addition to pharmacy residents, and this had allowed us to develop kind of this transitions of care pharmacy residency. Although they're not fully here in person, they are always working alongside with us, even when they rotate throughout the hospital. So we have a dedicated transitions of care resident, which has been really helpful. I think we will constantly, as any institution, advocating for this. As Kevin said, the quality of the work that we know, and specifically what Sarah and I were focusing on was children with medical complexity, it's really important with the transition of care to home and how we deliver it and how we set the family up for success. So I think it's always ongoing discussion, how we can always do better as well.
Great, thanks. And again, for the group, do any of these sites require for the parent to come in and provide care to, I think, sort of demonstrate care prior to discharge? And if so, how do these initiatives kind of work in with that?
Well, I can address that. We do. We have. We plan for that. We plan for families to spend time here. We encourage families to be at the bedside as much as possible. And we partner with our families from the very beginning of their child's care all the way through discharge, with mutually agree upon what families want to be able to do and not do, what they want nurses to do. And then with teaching, we have it pretty spelt out as to which bites of the teaching you'll do each day, and then demonstrating back with teach back. And facilitating your comfort to being able to take your child home. Each family, it's individualized, and each diagnosis, it's individualized, but it's supported here, and that's part of that readiness, is that family's readiness and that nurse's ability to recognize that family's readiness.
Great, thank you. We have several people weighing in to sort of ask about how you ensure that you're communicating changes in the plan of care to relevant community stakeholders, whether it be the primary care physician, the school, community organizations. Anyone want to weigh in on those pieces?
I know from a standard here at Packard that we do amongst the board is we contact the primary care physician prior to discharge to explain the reason for admission and kind of a brief description of the inpatient hospitalization, and then also sending over records as needed. So I know that's one other initiative, not specifically for this collaborative, but that we do here at Packard.
And I will say that I think this is an area where we fall short, and I know many institutions do as well. Our system in Epic is set up so that the hospital notes automatically go to the physicians, primary care physicians. But of course, that always is fraught with complications if they're not set up correctly in Epic or their fax numbers are wrong. And it often falls on the pediatricians to follow up on things that have been missed in the hospitals. I was talking about before with the medications, if it went to the wrong pharmacy and the family ends up calling the pediatricians, and they're sometimes put in a tough spot. So we do, as part of our program, if there's a very complicated discharge, particularly if the pediatrician is not as familiar with the patient, we will call them and give them a heads up about why they were admitted and things to look out for if they call. And we are always available to our pediatricians in the community to call and have us paged to discuss the patients.
Terrific, thank you. Kevin, a question for you. You mentioned that the 10 discharge standards were narrowed down to 3. And what national qualifiers or benchmark did you adopt those 3 from, and what was the process?
Ooh, great question. So we thought the best way to narrow to those 3 standards was to use a systematized prioritization approach. And so we used a technique called discrete choice experimentation, which is often used in economics or the business world when you're interested in kind of doing some market testing about, would you rather prefer Pepsi or Coke or something like that. And what we thought was, let's apply that same statistical process to prioritizing which standards for our institutions to adopt. So we took those 10 standards and we surveyed not only our collaborative members, both our site leads and their co-leads, but we sent a survey that kind of set up these discrete choice experiments, which there's this entire process of how you do that. But we had hospital administrators complete that. And then we also partnered with Family Voices of California to do the exact same thing. And so it was something over 25 or 30 questions, kind of doing, please rate out of these 4 things, in this situation, what is the most important thing to you? What's the least important? And if you do that enough times, you get enough data points that you can kind of throw it into some statistical software, and it spits out some things that tell you overall, these are kind of what bubbled to the top for everybody, and these are kind of what fell to the bottom. And so we used that objective piece to kind of gather data, but we also felt like there had to be some sort of qualitative conversation around it as well. So we did all this ahead of our first kind of in-person meeting, and during our first in-person meeting, we presented, in the true spirit of PAR, we presented that quantitative data to our colleagues, and they our collaborative colleagues, and had them chew on that and kind of interpret, what do you think the differences are between administrators rating these 3 things as the most important as opposed to families rating these 3 things most important. We had our family members weigh in as well as our advisory panel. And in the end, we came together, and I think we gave everybody I think 3 green stickers out of the 10, and put up all of the 10 standards all on the wall. And we had everybody kind of for their own institution and kind of looking at the gaps in care and what they could improve on, take 3 green stickers and place it on the things that you do well, take 3 red stickers and place it on the 3 that you think you could use some improvement, and then digested that even further. And ultimately, I think gave 3 final green stickers to everybody and said, go vote. And then the top 3 were what we walked away with.
Terrific, thanks. We are coming to the end of our time together. Really have appreciated hearing each of the speakers describe their work and answering all of the questions. There are a lot of questions that we didn't get a chance to answer, and so we are going to respond to those questions, and we'll get them sent out to everybody who registered in the coming weeks. Thanks everyone for joining us today. You can get more information about our work by visiting the Lucille Packard Foundation for Children's Health website, and we hope that you found the discussion informative and hope that you have a great day.